Thank you for the opportunity to present our work here today. I have no disclosures. Penetrating thoracic injuries in the pediatric population are infrequent, but often result in mortality or significant post-injury morbidity. While the majority of penetrating thoracic trauma is managed non-operatively in adults, children require surgery more often. Previous literature has demonstrated that case volume and center designation may impact outcomes after certain injury patterns in adults. However, little is known about the impact of these factors on outcomes after pediatric thoracic trauma. We sought to determine the impact of hospital designation and penetrating trauma volume on outcomes after pediatric penetrating thoracic injuries. We hypothesized that higher trauma center level designation and a greater annual volume of penetrating trauma cases would be associated with improved outcomes. We conducted a retrospective study using the National Trauma Data Bank from 2013 to 2016. Our study population consisted of patients less than 18 years old with penetrating thoracic injuries. The primary outcome evaluated was mortality. Treating centers were categorized as adult or pediatric and by trauma center level. Center performance was calculated as the difference between observed and expected mortality using the trauma mortality predictive model. Pearson correlation and mixed effects linear regression were used to compare center performance. Overall, 4,134 patients were identified with a mean age of 14.7 and a median injury severity score of 10. Firearm-related trauma was more common, and these patients had higher median injury severity scores and significantly higher mortality. Because firearm-related injuries represented the most significant risk factor for death in penetrating thoracic trauma, we chose to evaluate center performance specifically with respect to these injuries. Shown here are the beta estimates calculated using linear regression after accounting for age, injury severity score, and clustering by center. Using adult level 1 centers as the reference, you can see that these centers had superior performance compared with all other adult centers. For example, because the beta estimate for level 2 adult centers is 11.1 in firearm-related thoracic trauma, if we moved all patients treated at adult level 1 centers to adult level 2 centers, we would expect there to be approximately 11 more deaths. There was no significant difference in mortality between pediatric and adult level 1 centers. Lastly, we evaluated the relationship between penetrating trauma case volume and trauma center performance index. Performance index is shown on the y-axis and improves as the number becomes more negative. In firearm-related trauma, which is represented by the darker line, there is clearly a significant correlation between higher annual penetrating trauma case volume and improved center performance. There was no significant trend noted in stab-related injuries. In conclusion, firearm-related injuries cause the majority of deaths after pediatric penetrating thoracic trauma. Adult level 1 center designation and higher volume of penetrating trauma are associated with improved mortality after these injuries. Prospective study would help us to identify factors at higher volume centers that improve outcomes and can be instituted at lower volume centers in order to improve performance. Thank you again for the opportunity to present our work.